Could you please introduce yourself and explain your involvement in PSSRU?
I can do that. I'm David Jolley and I'm an old age psychiatrist. So I started working in the field in the 1970s, and very quickly, I was a clinician along with other clinicians, and very quickly we learned about the activities at Kent with David Jolley and David Davis, and it's been marvellous to be able to work alongside such people. So I've got on with my career in various places, and then it's been my opportunity since 2006 to actually be part of this unit, which has been just terrific. I came wanting to just keep going with some activity that I was already involved with, but I've been very generously included in a number of other projects, which has taught me quite a lot and hopefully is a bit helpful to the people here.
And so how has PSSRU changed since you first got involved down in Kent's work?
They're all over the place, aren't they? I mean, they've, influencing people here, there and everywhere. And they produced these two, frightening grey books. One was rather thin and one was extremely fat. And it was like the Bible and the New Testament sort of thing for everybody. So it started off, I think, with Brendan Davis's vision of doing these things, but it very quickly was seen to have the potential, and has spread. So it's there in London, it's there in Kent, and it was a marvellous thing when David came up here. So from something small, something important, really generalised within this country, and of course internationally recognised, and the ideas and the approaches used and developed. It's done all that. Yeah.
And what were your fondest memories, especially of those earlier days?
Yes. Well, of course, my personal involvement here has been since 2006, so I just love all the people that I've met. I mean, they've been smashing people here. But in the beginning, it was just meeting with David and Brendan Davis. I remember it, cafe after meeting, and you're just listening and talking to these ideas. And I mean, the biggest thing for me was, such sensible approaches. So not sort of hidebound by the systems of the time, but sort of respecting people who've got illnesses, people who care about them, and marshalling sensible ideas and everybody's resource to get things done. Talking to people like people instead of, as if they're different specimens. So that's, just real people.
And tell me about the areas of work that you focused on during your time here in Manchester.
Yeah. I mean, at the beginning, what we were doing was developing services and getting services going. And the PSSRU people were interested in that. They picked it up and they worked with other colleagues, particularly Alistair MacDonald in London. So since I've been here back in Manchester from 2006, my own things work in NOSL, in primary care, and people here have been interested in that and helped us develop and spread the gospel of that. And I do work in a hospice, so end of life care has been thing. But there have been other projects which has been marvellous with Nitin and David and others looking at particularly South Asian populations, their understanding of dementia and how we can work with those understandings to get better exchange of knowledge and ideas to good effect, and we're still working on that. Something slightly, quite different. There's been involvement in a European study. I think it's 7 different countries looking at dementia on the cusp. People at home, can they stay there? What does it look like in the different countries? So that's been, for me, marvellous to see all these, to meet all these other people and understand what the differences are. Being an older person in Northern Europe, you're probably in a flat by yourself down in Spain. You're surrounded by all sorts of noisy people who want to, it's a different world, and here we are, on our island. So that's been marvellous. So I'm being allowed to be involved in a number of things. At the moment I'm involved in a couple of things. One's about dementia and initiatives in dementia. The other's, if you like, general psychiatry services for people who are not yet old but have got mental health problems and looking at those issues. So that's been a wide spectrum.
And thinking back through that, which do you think are the professional achievements that you're most proud of?
Yeah, the most. I'm proud really of the origins. I mean, when I was appointed in 1975, there were no specialist services for older people with mental health problems in this part of the country, in the northwest. So off we went. Surviving has been, the first thing to do, and the growth of that service, helped by evidence base from PSSRU and other people. It's been amazing. So where there was just me, there's now quite a lot of people. That's been helped in part by academic people, but also by the college and by nursing people, social care people who have seen it as an important thing to do. So seeing that spread has been good. I'm particularly pleased that Manchester has become such a centre of excellence. The first few years we got on and did what we could. We then found bits of money from various places, and we were able to appoint a professor of old age psychiatry, which is Alistair Burns, and a professor of social care of older people. I'm not sure if that's exactly the right title. And that was David, and that brought the PSSRU up here. So we've had massively improved teaching, research across the spectrum of clinical issues, basic biological issues and social care issues, contributing to the world's advances. So I didn't do much about it, but I was there. I was there, as Max Boyce used to say. He probably still does say.
Thinking of PSSRU as a whole, over the 40 years, what do you think has had the biggest impact on the lives of service users?
I think the biggest thing is the increased respect that's come to people's families and individuals with dementia and other conditions, the involvement and the listening to them. Crossing boundaries, if you like, of healthcare and social care, but also working just with families and voluntary organisations as far as greatly helping the move away from institutional care towards more care in the community and actually meaningful care in the situation that people want to be looked after in. And latterly we're seeing with government interest and influence, money being processed to people and for people, and that doesn't suit everybody. But I think it is a very important move that is giving power and influence to people who actually are the, if you like, consumers in those ways. Yeah.
And over the years, how do you think the relationship between social care research and frontline practice has changed?
I'm just a frontline practitioner, and if they will listen to me, and others like me, preferably me, they will be getting it right. I'm not sure they listen to us any more than they did. I think it's probably just the same, they think they know things and we think we know things. But overall, I think we have found ways of coming together. We have the dreadful common enemy of management these days, of course. I don't know how we can change that.
If you had the power to introduce a single social care policy tomorrow, what would that be?
Yeah, I saw the question and I thought, I think the thing that I'd really like to see looked at more is work, the availability of work for people with mental health problems. I mean, I've been shocked in the one project that we're involved with to find that you couldn't use a measure of employment to differentiate between people who might be in hospital or might be in the community, because none of them are in work. You know, the concept that work is therapeutic seems to have been forgotten about. You know, as I came into things as a student in the 1960s and then in the 1970s, there were people, you know, emphasising, their whole emphasis was to help people with serious mental illness to start to get back into work, rehabilitation, sheltered workshops and so on. And it's gone for now. And it's hugely damaging to the individuals. And on balance, it must be massively costly. At the moment, those people exposed to the benefit system, which seems to have become bitter and unfair. So work for people who've got particularly mental health problems was the thing I think really needs looking at properly again.
And lastly, what are the main issues facing social care over the next 10 years, do you think?
Well, there's quite a lot. There's the growth of older people, active older people, and people who are need help. Not everybody does, and the best use of that at the time of active people is very important. The growth of multi-ethnicity, it's in some towns and cities now, but it's becoming more generalised. That is a major issue. The requirement of all of us to have education on and on and on. An old lady was showing me her memoirs yesterday, and she had a quote which says, the first 40 years is the narrative, and everything after that is commentary. I had to say to her, I don't think that's right, because we keep on now, well beyond 40, well beyond 60 actually, increasing the narrative, if we're properly, you know, equipped. So that's a very important thing. There's putting together appropriate services, but in relationship to what people want and value rather than what people in control think and want, and the massive question of best use of resources. I think that's going to be best done by reinventing, re-strengthening awareness of local villages. Some villages have got grass around them, you know, fields and so on, as in no sort. But most towns, cities and so on, we all live in villages. And that needs a bit more sort of help and engineering. Parks, churches, schools, doctors' surgeries, these are the things that people cluster around. And I think if people can get ownership and control of what happens locally, then it sums up. Rather than everybody saying, why don't they do things better? Aren't they terrible people? And so on, because it's us, obviously. So I hope people can take the risk of allowing us to do that in these changing times.
A wonderful final thought. Thank you very much, Dave.